Awesome. So my name's Orr Shauly. I'm a plastic surgery resident at Emory University. Thank you so much for allowing me to present today. I'll be talking about a pretty interesting case study that we just wrote up, the lightning LeFort, a most unusual vector. So our patient was a 70-year-old male. He's status post lightning strike. He had no fall. He had no loss of consciousness. When he arrived, his airway was intact. He had bilateral breath sounds. His circulation was fine. GCS was 14. He was just a little bit confused and couldn't hear out of one of his ears. And he had about 6% TBSA burns to his left upper extremity. Interestingly enough, without a fall, we only found on secondary survey that he actually had bilateral non-hemorrhagic inferior frontal lobe contusions, a left LeFort type 2 and type 3 fracture on the right, a left superior retrobulbar hematoma, exophthalmos, superior orbital soft tissue lacerations, a ruptured left TM, and a second lumbar transverse process fracture and a third lumbar vertebral body fracture. So very interesting. The mechanism of this was so lightning strikes. He was about to enter his car during a thunderstorm. The chassis of his car is made up of metal, so the lightning strikes the car frame. It travels around the vehicle, and normally it exits through the ground and through the car tires, since that's a grounding point. He had an older vehicle, and so the handle of his car was actually made out of metal. And so the exit point, it actually grounded through his body. So he grabbed the car with his left hand, and it got grounded through his body. So he had those burns on his left hand, and the force of the lightning strike actually threw him backwards, pretty forcefully. So just in general for lightning strike workups, initially you want to look for monitor their creatinine, watch for myoglobinuria and AKI, resuscitate appropriately as needed. You monitor their CPK and resuscitate to a goal urine output of about 50 to 100 cc's per hour. You monitor the troponins for any myocardial injury, as well as EKGs. TTEs are indicated in these cases, even with normal troponins and no EKG changes. And then we obviously did upper extremity neurovascular checks, Q1 hour, and then a little bit more spread out once we kind of figured everything was okay. And then obviously assessing his burns. In his case, interestingly enough, his troponins peaked within the first 24 hours at 1300, but immediately kind of troughed right after. We consulted neurosurgery for any seizure considerations, especially since he had those bifrontal contusions. Plastic surgery was consulted for facial fractures. Cardiology was consulted, obviously, for the any cardiac implications. ENT for this tympanic rupture. Ophthalmology for baseline exam. And this is actually a very interesting point, is that patients with lightning strike injuries may not present initially with any ophthalmologic concerns, but they actually can have long-term cataract issues due to the way that the lightning strike changes some of the proteins in the lens. And then, of course, monitoring renal function. From a burn standpoint, the preoperative diagnosis were intermittent, indeterminate depth burns to the left upper extremity and part of his left upper torso and the posterior shoulder. We debrided it in the operating room on post-op day 4, and we found just second degree, actually mostly superficial burns, and just placed a temporizing dressing permeaderm. So kind of interesting role of temporary skin substitutes, especially in these superficial burns from lightning strikes. Role is to kind of augment the natural healing process, improve the resulting scar, and reduce kind of heal time. You obviously have biologics like allografts, and cadaveric human donors or xenografts made out of porcine. And then there's synthetic options, which kind of mimic the function of the native skin, reduce evaporative fluid losses through this large surface area, promote kind of healing and migration of the healing cells into the wound bed. And so in this case, we used PermeaDerm, which is a bilaminate matrix made out of nylon mesh with a silicone coat with aloe vera extract infused. This allows, again, for kind of effusion of fluids, but also kind of temporizing those evaporative, or kind of limiting those evaporative losses, but also promotes kind of wound healing on that wound bed. So this was his initial presentation. That's him post debridement prior to the OR. And then here is on the bottom is what it looked like after we took off the permeaderm. This is 1 week post-op. This is 2 weeks post-op. He has a little bit of hypergranulation tissue, which we just treated with some silver nitrate. This is 3 months post-op, looks very, very good. And so in terms of his LeFort fractures, so actually very interesting pathology from a fracture standpoint. So LeFort fractures in general are fractures in the midface, which involve separation of any part of the skull base from any part of the skull. And so LeFort type 1 is usually caused by a force directed low on the maxillary rim and in a downward direction. And then LeFort type 2, which is kind of the similar to his injury pattern, is usually a force to lower mid-axillary line. And then type 3 LeForts are usually from direct anterior impact to the nasal bridge or upper part of the maxilla. But the key part is the definition of any LeFort fracture are going to be fractures that extend through the pterygoid plates through the maxilla. And here's a kind of depiction of that. So in this case, his fractures were actually LeFort-like fractures because they did not involve the pterygoid plates, and this is fairly unusual. But this was because instead of a downward directed force or anterior directed force, this was actually an up and out directed force, since it traveled up his arm and then traveled to the ground. And so very interesting. And here's a depiction of the pterygoid plates on the bottom right corner. So fracture management, for most cases in these LeFort-like fractures, it's observation, and if non or minimally mobile, with unaffected occlusion. And so that was the case with this patient. If there's any minor malocclusion, then we often do maxillo-mandibular fixation with no open reduction. And then, of course, if we're unable to achieve that reduction with closed fixation, then we do open reduction to achieve good dental premorbid occlusion and correct any facial deformity. Interesting enough, in most cases of LeFort-like fractures, if there are no associated mandibular fractures, patients are often treated just with observation because there's no maxillo-mandibular mandibular dissociation. So that's the presentation. Thank you so much for the opportunity to present. Let me know if you have any questions.
Great job. That was very interesting. I have a question about some of the skin substitutes that you use, the permeaderm. Could you talk a little bit more about that and like what the advantages of the permeaderm
Yes, so this is actually something that we started using pretty recently. And it's pretty advantageous because not only is it semi-permeable, but the pore size allows for good evaporative fluid losses, but also it doesn't allow for an accumulation of any material or exudate underneath the dressing. And so because of that, we found over the last few months that these wounds heal really, really well because it allows the kind of temporizing part of this bilaminate matrix, so the kind of the part that's in contact with the skin, to actually do what it's supposed to do, which is promote wound healing. A lot of other temporizing dressings, like Integra or others, oftentimes there's a large accumulation of fluid, and that causes kind of a barrier between the dressing and the underlying wound bed. And then also another huge advantage of this is that it's actually very flexible. And so it's very, very great for kind of convex or concave surfaces, or basically any surface with any sort of convexity, because it's very flexible and kind of contours really well to the wound.
Nice. How does infection play a role? Is it better or worse with infection?
I don't,
And then
Yeah, that's a really good question. So right now there isn't really any data to show that PermeaDerm has any kind of well, there's no good data to show. There's a sponsored study, industry sponsored study that shows there's a lower rate of infection, but there's no kind of high quality data to show that there's any difference between any of the other silicone based dressings. I think we found just within our hospital, our system, that we've found a much lower rate of infection, just again because it allows the wound bed to be pretty breathable too, and so it doesn't allow for a lot of buildup of exudate underneath the dressing.